Dear colleagues, we have the pleasure to work here with Professor Business today on a very challenging case of below the knee occlusion. I've made a short presentation, maybe you can put it on, but we have a 72 years old male who is complaining of short claudication. 6 months ago, he underwent an open surgery for acute occlusion. So this is done by below the knee incision and the separate incisions for the anterior and the posterior tibial artery. Yesterday, when I spoke with the patient, he shared that his anterior wound was not healing properly several months after the operation. So this puts the patient in another category. So now, Professor Business will tell you some more about our strategy.
So hi everybody, thank you for the kind invitation and thank you also for the hospitality here in this cath lab. This case is a challenging case because we have the endarterectomy of the popliteal artery. So we have the stent has no stenosis, we will see now the angio. And the point is we don't know what happens with the peds, not with the peds, with the reconstruction of the artery. If we have thrombus inside them, the outflow is really very full. We have only a patent tibial artery, and the posterior tibial artery has contrast agent at the distal part through collaterals from the fibular artery, and we cannot really assess what happened with the distal part of let's say, with the pedal artery, with the dorsal pedal artery. Can we see the angios just to show? Here is the situation. You see the occlusion at the level of the tissue segment. There are some few collaterals. Then we have a patent tibiofibular trunk with a patent also origin for the anterior tibial artery, the next one. Then we have some collaterals. Can we go one back? Here you are. Okay. So you see some good collaterals that provides blood into the fibular artery. The fibular artery has a high-grade stenosis. This needs to be treated, and then a slow flow, probably due to the fact that we have the sheath inside the SFA up to the stent. And go next one. The anterior tibial artery seems to be diseased, and then through the fibular artery, you can appreciate some collaterals to the posterior tibial artery. The patient moved at that time the forefoot, but you can appreciate that the posterior tibial artery probably is the vessel that at the moment saves the foot. So what we have done here is that we have already inserted a 6F Fortress sheath, the sheath from Biotronic. You can select whatever you want. The point is you have to go as distally as possible in order to have enough pushability. So we are now up to the end of the sheath, so we cannot go further distally. And then we decided to go for a support catheter. We are using the Cornelian catheter from Biotronic, which is an O18 platform, and through this a Command 18 wire. So the strategy now is to try to penetrate and to advance to penetrate the proximal cap of this occlusion to assess how smoothly the wire will get through the lesion. This is the so-called traversal wire test. If it goes very smoothly, we have high suspicion of thrombus. And then to support everything with a Cornelian catheter. After this, we will do a small angioplasty with a small balloon, 3 millimeter. We want just to make a small channel, and we will decide how we will go further after the angio. You can go further. Okay. Now Nikolai will go further. Perfect. And here you see it goes relatively smoothly. Let's see here what happened.
Okay. Do you want to make an angio here to see?
Yeah, let's go further a little bit.
Okay.
Okay, you are probably in the anterior. Try to.
Yes.
So you see he rotates very nicely the wire. I'm going further.
I'll try to rotate it down.
Let's make a small angio here to see what happens.
See where we are. Okay.
So it was very smooth. We have no backflow. Let's see.
Try to test it.
I will do first an angio from the sixth, just to see how closely we are to the.
Okay.
Okay, we need a little bit more.
Okay.
Okay, let's try further. So if you don't have any backflow, don't try to do any kind of angio from the support catheter, because the contrast is staying inside the lesion. It causes only problems, and maybe you are on a dissection membrane, you may make it really more difficult. You see how it looks like. We have to further work on this. Let's go back, go further. Okay, here you are. It looks.
Okay.
Let me go. Let me come. Stay.
Okay.
Keep the wire.
Okay.
Okay, here you are.
Again, going.
Go back. So we have to. Can you show me the angio that we have done, just to make a marker? Here you are. So the beginning is the part of the fibula.
Can we work on roadmap here?
Yeah, let's do the roadmap just to be sure that we are probably going into this collateral.
Yes.
We will see now. Tell us when we are ready with the roadmap.
Can we use the roadmap?
I think so, yeah. Okay.
Okay.
It doesn't here. Okay, it's good.
Some insight regarding the wire you are using?
Perfect.
Command.
Yeah.
Command.
This
Okay.
one.
Try something.
Okay, of course.
So here, this loop is not really the best thing that you have to do. Let me go a little bit with a loop. This is probably the cap that you have to penetrate, and then you are probably right in the fibular artery. That is what we want to go. Go a little bit distally. Okay. Let's see here. Here's the collateral. Probably you can go back. Okay. Let's remove the wire just to see where we are.
Okay. We're removing the wire.
So here there is now backflow. That is a very good sign. And this is what we need to have. Give me a little bit more fast.
Yeah.
Okay. Always aspirate. Okay, this is the posterior tibial. That's fine as well. Okay, perfect. Great. Okay, let's put again the O18. And let's open the first balloon, the 3 millimeter balloon, just to do a vessel prep.
Are we going into the perineum, or we can stay in the posterior?
I will say let's take the posterior.
Okay.
Because at the moment it matters to open.
Okay.
Let's go down further. It's okay. Here is enough. Let's go a little bit further. Doctor?
Yes. Let's see.
This is an 018 wire. It's not the best thing. Let's go here. Here's probably collateral.
Yes, it's going to a side branch.
Yep. Let's go back. That is better.
No.
Okay, let's go up to that level. No. No. Okay. I'm trying to go very controlled. Probably we will see where we are.
It looks promising.
Yep.
I'll go further down. Okay, that's the posterior.
Probably we will see. Okay, let's do an angio.
Okay.
Because this is a 90 millimeter balloon, and it's okay. Okay. We cannot see anything. It's closing. Can we change for a longer support catheter? Yes, please. Yes, yes. 100. The next long. You can
Okay, this
remove
one.
it. Okay, forgive me.
Okay.
Okay. The wire is long enough. The command is the long. Okay.
Absolutely, yes.
Let's see where we are. So it is good that we are down to this part. We will see if we are inside the artery, but it seems that we are in a right position because you see here the artery, it goes directly to the posterior. We will stop here. Okay, that's nice. Good. We will check just to be sure that we are inside, even we will see that everything is fine because the command 18 is an aggressive one, but I'm pretty sure that we are in the right position. The posterior tibial artery was also the most important runoff. So do you have any question until we have the catheter, the support catheter?
Are you planning to change the wire? With which one?
At the moment, not yet. So we can do this to change the wire, but I'm also starting using more frequent 018 wires for below the knee, especially if we have patients like the one here with relatively big vessels. So, but we will see. We're going to use a 3 millimeter balloon, and we will see. But do we have a command 14?
Yes, we do.
Okay, we will see. Do you have 2 millimeter balloon catheters or? Okay. Due to the fact that we have 2 millimeter balloon catheters and they cannot go through the. Let's see where we are now.
Yeah, I believe
Here?
we're down here. No, that's right.
That's
on
right.
the tibia.
Okay. Now it's going to be a little bit.
Then you feel safe ballooning over this wire.
Go inside. Okay. Sorry, I couldn't hear.
You feel safe ballooning over this wire then?
Yeah.
Because you are now in the distal part of the posterior tibial artery, so it seems a bit. I have some safety concerns. Maybe it's better to go with the microcatheter till the end and then change the wire.
This is a support catheter. The support catheter is one of the safest, let's say, ways to check this everything here.
We're removing it.
Yes, yes, please. And now I will change for an 014. Let's see, however, if we are in the right
014.
position.
Command 14.
Important is always to see it in different. Okay.
Do you want to make an angio?
Yes, please, an angio.
Okay.
It was a nice crossing though.
Yep.
Nice demonstration.
Don't move
Не
it.
мърдай. Не мърдай, стой спокойно.
Okay.
Okay. Okay.
Yeah, it looks good.
You're definitely in.
So, command 14.
We have small
Perfect. Here you are. What is your workhorse wires? I mean, I really like the command wires, 18 and 14.
Okay. Моля те, не мърдай. Моля те, стой спокойно.
Is this a support catheter O35 or O18 or 14?
It's 018.
I can't.
018.
018.
018.
Okay.
Okay, go there. Loop is fine. Okay, you can remove it.
Okay.
And then we will start. You can open the tube. Perfect. Perfect. So we're going to use, which one? The Paseo 14 to 140. Just to go to do first dilatation to check what happens. The point is, it could be a very good reason why this reconstruction was occluded, that the outflow was not the best one. Only with a fibular artery with an occluded posterior tibial, it could be the reason.
I'm only worried that the O14 guide wire won't give us enough support because we have difficulty passing through the thrombus with the supporting catheter.
It's time to assess the efficacy of Paseo 14.
Exactly.
Yeah. So let's see what Biotronic says, if this is really has good trackability.
Da.
So I think that it is crucial here to open one of the three vessels because the tubular artery gives some branches, but I don't think that would be enough. And even if we have to stent further the popliteal segment, then we may need to, or not, we put at risk the new stent. So I think we need at least one good patent vessel up to the forefoot. And due to the fact that the wound is on the inner part of the foot, I think we need some kind of more blood at that level just to have also a healing there.
Perfect.
So, do you have the wire? Okay, it's fixed.
Yes, of course.
Perfect. I think the vessel was patent up to it was closed up to the ankle. We go as distally as possible. Here we have some difficulties. Let's see. Okay. Here you are. Just keep the wire.
Okay, it stopped here the last time.
I'm trying to do this.
Do you want to make a small inflation here just to open?
Yes, let me try to go as distally as possible.
The guide wire is going a little bit out.
Okay, put the guide wire inside.
Okay.
And now let's do the first. Okay, let's see.
Well, it's kind of difficult.
Okay, go back. Here you are.
Was das an ipsilateral approach, access, or contralateral? I missed
It's
it.
under great access, ipsilateral. Okay, let's do the first balloon.
Okay. Starting slow.
Yes.
We are on 6 now.
Go further, 8, just open.
Okay, it's safe. That's some air inside.
An ipsilateral approach is wise because if you want to go around the arc, sometimes if you go contralateral, so you don't have enough space with your microcatheter, with your balloons, and then you have trouble if the patient is a long one. So when you have the intention to go below the knee or below the arc, so ipsilateral approach would be always more appropriate than the contralateral one.
The nice trick of Nikolai that he opened first. That means it makes a channel. Okay, let's open again.
Okay.
Try to straighten the balloon.
Okay.
Perfect.
Down.
The balloon
So
is
what
2
we're
point
doing
what?
Sorry?
The balloon is 2 point what? The length?
2.150.
Okay.
Well, 140, sorry. Let's go further.
Okay.
It gets better. And go
Can you give us during working a bit information about your wires, because these wires are not familiar to me, so I use always the wires from the Asahi and CTO wires for the coronary. So the command wires, the 018, 014.
There is a command wires from Abbott.
Yeah.
There is a platform for There is a platform for 018 and 014. I cannot recall how much is a gram. I mean, what is the weight of the wire?
It's about 4 grams, I think.
I think as well. So, and in our opinion, this is one of the best wires to really advance through this kind of lesions. If we are not able to go with a command, because it has very good steerability, and if we cannot go with the command, then we are changing for a Asahi wire like a Stato, where we need more grams to penetrate really calcified lesions. But for this fibrotic or highly stenotic calcified lesions is one of the best wire at the moment at the market, according to, of course, my opinion. Let's put out a zoom out.
Yeah, in my armamentarium, I have over 10 wires, so I can use them and change them. But when I see operators doing this with command wires, they rely on just 1 or 2 wires. The command wires, they like it so much. So I wanted to know what the features of this wire is.
Yeah.
So we can use Regalia, we can use Gladius, we can use Gaia PV, and sometimes if you have a calcified lesion, we can use Albert. So we have a lot of options with the Asahi wires.
Even if it is an 18.
Even
So
for
we
the
will
BEC,
now
Pillar XT.
Sorry, go forward. I'm sorry.
No, I'm just making some talk and filling the gap. So I'm just talking.
What do you think about the tendency to undersize the balloons below the knee?
Yeah, sometimes it's a concern, but if you have underfilling, you don't know the actual vessel diameter. So ballooning with the smaller one and then going up further, I think it's the wise action, because if you have a dissection and the flow limiting dissection, that's not what we want below the knee. So I think 2 millimeter is okay. Maybe with nitrate injection and then doing an angiography, you can further decide what kind of balloon you want to use for further ballooning. So I think beginning with the two.
Would you use IVUS to size precisely the balloon?
You say IVUS?
Yes.
No, I don't use any IVUS below the knee, but it's wise, it can be done, and it will give you an actual information about the vessel diameter, and so you can go up safely with your balloon. It's safe, because this is a total occlusion, the artery is underfilled, and so you need the proper size of the balloon to have the best result. So IVUS, it could be good. Do you have an IVUS option? Would you do it? It would be very interesting if you have IVUS.
Well, I'm not pretty sure, but we can always ask.
It would be very interesting.
If you allow me, I'm Ivo Petrov. I'd like to suggest to inflate a little longer. So short inflation in such a diffuse calcific and atheromatous pathology is not a good idea. So you are working like just for pre-dilation. In case you want to have a definitive result, it's better to inflate a little longer, at least 30 seconds.
Yes, you're right, but at the moment we don't need to make any vessel prep. We need to open the channel. So for these reasons, we don't need to do for 30 seconds, because this balloon is even not touching the wall.
Okay, so this is pre-dilation.
Yeah, this is a 3 millimeter. The other
channel opening. Channel opening.
Yeah,
okay.
Channel opening, exactly. For the vessel prep, you are absolutely right, and you will see. We go now for a 4 millimeter. You can open. We can go for a 4 millimeter. Because at the moment, our big concern is that if we have any thrombus inside this reconstruction. So when we are doing this, we are going now for a 4 millimeter balloon. And then after the 4 millimeter balloon, we're going to stay a little bit longer.
Do you plan to use a scoring balloon or chocolate balloon?
Yeah, probably chocolate balloon, but we will see now how it looks like. Do you have the chocolate?
Yes, we have chocolate 580.
That's good.
The proximal part seems a bit calcified, but you can also do calcification in the total occlusion part, but your wire was so easy to go. I think there was also some kind of thrombus involved in that total occlusion.
We will see now. Okay. It's not bad. Okay.
This is after 3 millimeter balloon.
Yeah. I would say let's go for a 4 millimeter, and then let's go for a 4
what
millimeter.
Ivo says is essential.
In my opinion, I will go now for a 4 millimeter to open a little bit more the proximal part of the lesion, and then afterward we will decide if we're going to go for a chocolate balloon. At the moment, I don't see really any suspicion of thrombus, but who knows?
I think you have to protect also the anterior tibial. It's going smaller and smaller.
Okay.
So what Ivo said is essential with long inflations. So my choice is always do it at least for 1 minute for the preparation. But as the operator said, if you want just to see the flow, that's the reason why he had so short balloons. I think he will go with the longer ones after this.
So let's put the 4 millimeter and let's
But the perineal trunk is very important. You don't want any dissection there, so you have to be very careful there, because if you have a flow limiting dissection, no one wants to stent that area. It's an awful area. If you go with a stent there, you have a lot of trouble.
When
we have to do it, then we do it, but that part.
We've measured it before the operation more than 4 millimeters. So,
However, I would disagree with you regarding the stenting of the tibiofibular trunk, because the current evidence shows that if you're using drug-eluting stents, balloon expandable drug-eluting stents at that level, actually they have amazing patency. So, in
Your
contrast, actually,
occlusion, your occlusion
I'm
begins in the
really,
popliteal area. With the peroneal
really,
trunk, you are right, yeah.
yeah, tibioperoneal
Yeah,
trunk.
yeah, yeah, you are right there. But the occlusion begins on the popliteal area, so
Yes.
you are ballooning now that area. I mean,
Vassil.
at that point, it's not what we want.
it appears.
Okay, good thing.
Is
So
it
now we will
is it
stay for
chocolate
30
balloon?
seconds. No, not yet. This is a 4 millimeter, just a 4 millimeter balloon. In case that you are in trouble and you have concerns about if you have thrombus, the best strategy, if you don't have distal protection devices, if you don't have any thrombectomy devices, the best protection would be to go slowly and to starting dilating for 3 to 4 to 5 millimeter, just to try to not to really fragmenting the whole clotting side. And we will see how it looks like after each angioplasty, and then at the end we will decide if we go for a stenting or if we have any other trouble here. An alternative could be to give some RTPA inside the thrombus. There is a nice trick that we have now discussed before, to take a pigtail catheter, to use the 018 wire, to use a side port through a T-burst, and then we are using the side holes of the pigtail. You are providing contrast agent just to see how it looks like the lesion. This is very nice if you have really big vessels. If you have thrombus, you will see the contrast stain inside the lesion, and you have a very classical picture of the thrombus. And at the same time, you can really inject, without losing the wire, you can inject some RTPA from the side holes of the pigtail. This is what we're doing, for example, in vein thrombectomies, where we want to go through the iliac veins. We are using the pigtail, we're injecting RTPA until we prepare the thrombectomy catheter. Is this penumbra or Rotarex or whatever you want? Then we are leaving enough time for RTPA to make the job. So, okay, let's open it a little bit to see what happened. I'll go a little bit down.
Okay.
Because here was the biggest problem. Okay.
Slow again.
Yep. So we have done a very interesting paper. We have written together with Jihad Mustafa from the US. We have done some nice IVUS measurements. And I have to say, in all the times, the IVUS showed bigger diameter than the angiography. So especially if you're using eluting drug-coating balloons below the knee, there is a nice, let's say, a nice quote from US, no touch, no drag. That means if you don't have really good diameter, then you will not have a drag on the vessel wall. And this is one of the arguments why impact deep trial didn't work in CLI patients, because the mean diameter of the drug-coated balloons that were used there was 2.5 millimeter. And this is actually too small for the below the knee arteries. Okay. If you had the opportunity to do this, would you use drug-coated balloons for below the knee arteries?
So I used it in the past a lot, but when the data come, the evidence come with no benefit of drug-coated balloons below the knee, I use it more less. So,
Okay.
and in my personal experience, if I have some kind of thrombotic lesions below the knee, I experienced some kind of slowing after drug-coated balloons. And I wonder why that happened. If I have, after normal ballooning with the same size, actual size, no problem. After you balloon with a drug-coated balloon, and the flow comes worse. And my personal experience was in accordance with the evidence that comes from randomized trials. So I am more cautious now using drug-coated balloons below the knee, but that's my personal experience.
You want to try the chocolate?
Now is a very good point. Let's discuss about this because this is. Can we stop the picture here? If it's perfect. So you see here we have already dissection, or who knows whatever it is. This thing there inside. So the chocolate balloon will not give us now an additional benefit because we cannot really fix this kind of material that is inside. Is it thrombus? Is a dissection? We see a dissection against the flow at the P3 segment, just 1 centimeter above the anterior tibial artery. So this may be gonna cause problems in the near future. And at the same time, in the middle, the P2 segment, this area, in my opinion, is not the best to work. There has been an endarterectomy at that level. That means actually we don't have media there because it has been removed due to the endarterectomy. So we can put, let's say, a DCB just to, let's say, reduce a little bit the inflammation and all this stuff that has been through the endarterectomy. But in my opinion, we have to stent it.
Yes, you're definitely right. But what do you think? Should we use the drug eluting technology before or after stenting?
Due to the fact that you don't know if it is a thrombus inside, I would use here first the stent and then the DCB.
Okay.
I don't know if the people agree in the audience and in the panel.
I think we
It is
could
a very.
go. I think we can go with the chocolate balloon if you have that for a more balloon inflation. At least give a chance for that region, because if we stent that region, the P2 segment, I think we will have not good results in the short and the midterm. So I think we have to give that a chance with the long balloon inflation, maybe with a more scaffolded balloon like a chocolate balloon.
Okay, let's try the
or
chocolate.
A scoring balloon. That's my opinion.
Scoring balloon is not a good idea. Give me the 5/120.
But you have always the chance to stent it after that. Already you wanted to stent it. So with the scoring balloon and longer inflation, there is calcium involved at that part, especially it's a very calcified one. So
you have to keep in mind this is a lesion that has undergone an endarterectomy. That means there is no calcification at that level.
Oh, okay.
That's the point.
Okay.
So I will use the chocolate. I will take
that region had undergone an endarterectomy?
Exactly.
Oh, okay. I missed that. Okay.
So that means there is no calcification at that level. However, we will try to open a little bit to do a vessel prep. I will not use scoring balloon because the scoring balloon has the wires outside the balloon, and this can really cause further fragmentation of the clot. The chocolate balloon, which has the cage inside, it's a very, very controlled angioplasty with the pillows.
Yeah, so, I mean the chocolate balloon. Yeah, okay. When I meant scoring, I meant with the chocolate balloon. Yeah, okay.
Theo, short question. If you have to stent, what kind would you use?
Well, actually, everyone would say here Supera. But I would not agree with this. In my opinion, there are very good stents, and due to the fact that the Supera has problems with opening due to the fibrotic lesion from the endarterectomy, I will use a classical bare metal stent here. But we will see. Look at this. This is the stenosis at that level.
Yeah.
That might be some error.
Hold some air.
I don't know.
Let's try.
It's possible. Let me get the air out.
Okay.
Let's try again.
But we can put a super as you wish. But I mean, I will even a pulsar stent will be nice here, or even a live stent from Bar. All of these stents are actually from all the stents that we have in the market for P3 segment. The only one that has approval is the live stent from BED. Let's open it. Go back and go. We will go back inside. Just a moment. In the middle.
I have another question for you.
Yes, please.
You said the first stent, then DCB. For how long do you keep the DCB inflated after you have stented?
2 minutes.
2 minutes.
Okay, and let's go back with our proceed.
Okay, yes.
So we will leave it here a little bit. So something is wrong with the balloon in the middle. but it's not bad. Okay, leave it here a little bit. So chocolate balloon is a good, actually a new good device in the market. We have, okay, that's fine. We have good results from the trial regarding dissection. This is actually the point. However, in my opinion, it doesn't work very well in calcified lesions. In calcified lesions, you need either debulking or you need, and I'm talking about severely calcified lesions, either you need debulking or you need, let's say, a stent graft and a supera, so the so-called pave and crack. At the moment, in my personal experience, I have not seen any other method that work good in really calcified lesions. The scoring balloon, it's a good idea if you don't have, let's say, atherectomies devices or the ability to use covered stents. However, in really calcified long CTOs, I still believe as a vascular surgeon that a good vein is the best solution. However, I would like to hear your opinion about this.
Theo? Ah, hello. What is the situation?
Okay, let's go back to the intro. We have already performed chocolate balloon, then a DCB, and then a standard and a DCB, and we have recanalized. You go back, please. You can go back.
Can we see the live case? We can.
This is the result after Stenting DCB. So we have, in my opinion, an excellent outcome.
Absolutely.
Yeah.
What we have seen before the operation. The tibial trunk we have touched it with the chocolate balloon. So we went up to 5 millimeter there, and also it is very nice. It is really a patent now. The anterior tibial artery, we don't care a lot because it is completely occluded. Our focus was the posterior tibial and the fibular artery. It has not any gangrene in the foot, so at the moment, in my opinion, we don't need to open it. And now we have used a 3 millimeter balloon catheter to open the posterior tibial artery. Show the next, please. Go. So this is the posterior tibial artery, is nicely patent. Go for the next, please. Next, please. And this is the posterior tibial artery that goes now up to the level of the forefoot and gives very nice branches up to the pedal arch. So we gave some papaverine, and now we want a little bit to touch the fibular artery at the very proximal part due to a high-grade stenosis in order to provide two-vessel run over him. Do you agree with everything?
We can vote if you want.
Yes.
Who is to open? As a cardiologist, I would do a short, non-compliant balloon at the ostium of the anterior tibial artery, and that's it, to keep it open. For
Yes,
me,
we will do
it's on the tips of your fingers, so it's not fair for this anterior tibial artery to be left behind. This is my personal opinion.
Theo, I agree with Ivo. So I think you should do something with the tibial anterior proximal part. You have done a great job. I know you are satisfied, and we are also satisfied with this result. But as you know, 2 is better than 1, 3 is better than 2. So I think you have time, and as you have succeeded so far, you should give it a try for the tibialis anterior artery.
Dear friends,
Yes.
the comment wire is not a good idea in this situation.
Yeah.
So I would choose something much more gentle, like even a whisper or probably whisper, some kind of hydrophilic wire with a good curve in order to get immediately there without any risk of dissection.
We will use a Berenstein catheter to go there. This is the classical technique for these cases. Now we want to take care about the fibular artery because this is an important vessel for us. Give me a contrast. Just a moment.
While you are working, can you give us also some information about the popliteal artery? I see a stent there. What kind of stent is this? And what was the result? I couldn't see the result after the balloon dilations. So I think it was necessary to put a stent there.
Go back to the angio. Yes, of course.
But your first intention was you planned to do it before see the result. So I think we should see the result after the ballooning.
Go Go back. Go back. Go back. Go back. Okay, show me there. So this is the result after the stenting.
Before the stenting.
Before the stenting, sorry, before the stenting. You see a recoil there. You see
Yeah, okay.
some kind of material inside, and I
Okay.
think this was also the problem for the occlusion. So this is the reason why we have stented. Then it was, and the next one, please show the next one. We use the Pulsar 18, a very flexible but with good radial force. This is the DC beam. You see there are some places where we have to further increase the lumen because there was a stenosis. Now it's really nicely open. And next one. And then we had a not good P3 to tibiofibular trunk. This vessel was more or less had some kind of stenosis there.
So this
and
is
for this reason we
a
use.
self-expandable stent? Can you?
This is a self-expandable, of course, self-expandable.
Is this Supera?
No.
No.
No, it's not Supera, it's a Pulsar 018.
Oh,
And
okay.
this is after
Okay,
the balloon, the P3 segment. And now the next one was what I showed you with the posterior tibial artery.
Okay, so far so good. Congratulations.
Yes.
But I think you needed double lumen catheter or something to engage the tibialis anterior artery because it's a 90-degree proximal the takeoff, so it's very difficult to get in there.
We will try another solution, and you will see if we cannot. Yes, we're gonna do this. This is a cardiological. Okay, open it.
So you
This
go
is a
first with the
cardiological
perineal. Okay.
Do you have a Bernstein?
Yes, we do.
Give us a Bernstein.
Theo, do you intend to use DCB in the crural arteries?
No.
No. Okay.
I'm getting it out.
Go a little bit here. Open it as well. So this is the fibular artery where we had some kind of stenosis. We wanted to be sure. Okay, there was no problem.
So the other colleagues from the panel, what do you think? 2 or 3 arteries?
Go back.
Dr. Nikolov?
Well, the procedure is too long now, and I think 2 is good enough.
Zoom out.
I would rather give it a try for the anterior because the patient has an unhealing wound in the distribution of the anterior tibial artery. And I believe it's doable.
We'll get the Bernstein.
Okay, good. Give me this one, just a moment.
Okay. You want to try without Bernstein?
I will try.
Continue with the presentation.
It's straight wow, it would be very difficult.
As a matter of fact, we are ready and I'm waiting to show you the final results.
With the help of a Bernstein catheter, we were able to go into the anterior tibial artery and go all the way down to the level of the ankle. And we inflated the whole segment with 3/0 long balloon. And after a couple of inflations, we had a very nice result, as you can see. Can you see the image?
Yes.
Okay, next. You can see the posterior tibial is open, the peroneal artery, and the last one. Next. This will be our final image.
Okay, congratulations, absolutely.
Did you try the anterior?
Beautiful. Yes, they fixed it.
Yes, we managed to go down, and when you perform a selective angiogram in the anterior tibial, it goes all the way down to the ankle level where it disappears and there is no constitution after that. But we tried for a couple of minutes to go past the occlusion at the distal level, but we decided it's not worth the risk. We have open posterior and peroneal, and in a claudicant, that seems enough.
Okay, thank you.
Okay, thank you.
You're welcome.